This video will demonstrate a routine Quervain's first extensor compartment release in a 45-year-old female. There was no history of trauma. The patient progressively developed increasing pain on the radial side of the wrist. She has a positive Finkelstein sign and visible swelling over the first compartment. This patient had failed a prior injection with corticosteroid. The procedure will be done under local with light IV sedation. We use a transverse incision directly over the radial side of the wrist. Once we infiltrated local anesthesia, light sedation is used. Limb exsanguination is critical since we will do this through a very limited approach and the anatomy needs to be clearly visualized. This will be approximately 1.5 centimeter transverse incision directly over the radial styloid. We initially need to elevate full thickness flaps so that we can place retractors and then identify the superficial radial nerve. That nerve will sit directly over the first extensor compartment, and we will try to release the compartment on its most dorsal aspect. For that reason, clear visualization is necessary with 2 radial retractors. Occasionally, a third retractor is necessary in order to be able to see the nerve clearly and release the compartment sufficiently. Typically, I will use a headset with loop magnification in order to be able to do this through this size incision. As mentioned, the compartment will be freed on its most dorsal aspect so that there is a volar rim of the compartment, which minimizes any chance of APL tendon subluxation. We often will find a separate subcompartment for the extensor pollicis brevis, as noted in the literature. Studies have shown that 80% of patients with Quervain's tendinosis have a separate EPB compartment. Tenosynovitis will be done as well in many cases in order to minimize the chance of recurrence. The subcompartment is released here with a combination of a 15 scalpel and the tenotomies. We often will remove a portion of the septum between the 2 compartments within that sole compartment. This is because many of these patients complain of a bump on the wrist even after the release is done. In many cases, we will identify a separate synovial cyst, which is excised at the time of the surgery. It is important to release both extensors proximally and distally. The APL tendon is typically retracted to the palmar side to then allow us to identify the EPB tendon separately as mentioned. Usually 2 separate 4-vicryl repeat sutures are used to close the wound with horizontal mattress stitches. This provides for strong repair and sutures that do not need to be removed. Bulky dressing is applied, but we do not use a splint as we encourage early, gentle use of the hand. The fingers are left completely free. The tourniquet is only released once the dressing is applied with some compression to it. Local anesthesia wears off within the hour, and we use simple analgesia post-op and immediate use of the hand. Most patients do not require physiotherapy. Thank you for your attention.